Sabbath to you. I need to hear happy Sabbath back. Very good, very good. Marcus, I'll be hosting the event today, and I want to thank each one of you for taking time out of your life to come to learn about how to live. Amen?
Amen.
That's what we're talking about this morning. So, the objective of this event is to bring awareness to your health, to make you more knowledgeable about how to take care of yourself, how to continually check with your doctor, your physicians, to see what's going on with you. It's to educate, to motivate you to get up out of the bed, get up off the sofa, get up out of the refrigerator. Some of y'all got that problem. And go to the doctor and check on yourself. We've put together a dream team, so to speak, of world-renowned professionals to give you information about how to better take care of yourself. From the medical aspect of it, the pharmaceutical aspect of it, as well as the psychological aspect of taking care of yourself. Now, this event is named after one of our greatest brothers, Clyde A. Pogue. He had a vision. He wanted to make sure the message of good health reached the hearts and the minds of all African American men and women, and just the world in general. So this is our second event, our second series in the event, and this event will take place, will be discussed about prostate cancer. Something that, as black men, we keep a dark secret. We don't want to go get checked. That being said, I'm going to ask Brother Barnes to come up and give you a little bio about Mr. Clyde Pogue.
Use this right here. Can everybody hear me?
Yes, sir.
Good morning.
Good morning.
It is with both joy and gratitude that I stand before you today at the Clyde A. Pogue Men's Health Conference Series. A gathering that is more than just a conference. It's a movement, a mission, a living legacy. And that legacy bears the name of a man who dedicated his life to strengthening individuals, families, and communities through compassion, wisdom, and action. Brother Clyde A. Pogue. Can we give him a hand clap? Today, we don't just remember Brother Pogue, we celebrate him. We celebrate a life lived with extraordinary purpose, a life that touched countless others through counseling, mentoring, ministry, service, and an unwavering love for his fellow man. Born in East St. Louis, Illinois, Brother Pogue's journey led him from Lincoln Senior High School to Tennessee State University, and on to the St. Louis University School of Social Work. But while his academic credentials were impressive, what made him remarkable wasn't found on paper. It was how he used his knowledge to build up others. He began his career in service to others in the United States Army, where he served as a medic and later as a clinical social work psychology specialist. His work didn't stop there. He went on to coordinate aftercare services in Illinois, served veterans in Michigan, and found the Grand Rapids Veterans Readjustment Counseling Center, helping heal the invisible wounds of those who had served. Brother Pogue was a man who didn't just respond to problems, he created solutions. When others saw barriers, he saw blueprints. Following Hurricane Andrew, he helped launch the first Shelter Plus Care homeless veterans program in the country, securing $3.5 million in funding for those who had nowhere else to turn. He authored treatment strategies, chaired national working groups, and received a congressional award and numerous honors for his innovative and compassionate leadership. But perhaps his most enduring accomplishment was the way he made people feel seen, heard, and valued. That's the spirit behind this conference. Brother Pogue believed men's health is community health. He believed that when men are mentally, physically, and spiritually strong, they become better fathers, better leaders, better partners, and better builders of the future. Together with his beloved wife, Donna, he built rational training and counseling associates to serve families, churches, institutions, and government agencies across the country. Whether consulting on juvenile justice reform, leading couples ministry at Lake Providence Missionary Baptist Church, or training therapists in cognitive behavioral therapy, Brother Poe poured himself into the work of healing and empowerment. He mentored youth through Kappa League. He led as a life member of Kappa Alpha Psi fraternity, where he served as pole mark, advisor, and guiding light to many young men. He stood tall as a 32-degree Mason, Shriner, and past master of North Star Lodge number 5. Always grounded in service, faith, and brotherhood. Brother Poe's life reminds us that the health is more than a physical condition. It is emotional strength, spiritual grounding, and the ability to give and receive love. And today, as we open this conference in his name, we carry forward that holistic vision of wellness, a vision rooted in equity, dignity, and care for one another. This conference is not just about raising awareness, it's about building bridges. It's about empowering men to take charge of their health, seek support, and live fully. That is the torch Brother Poe lit, and we now carry it forward with pride. To his family, we say thank you for sharing him with us. To those of us inspired by his life, let's honor him not only with words, but with action. Let's do the work. Let's encourage our brothers, let's care for our communities, and let's ensure that the Clyde A. Poe Men's Health Conference continues to be a beacon for generations to come. Brother Poe may no longer walk among us, but his influence, his values, his love for humanity live in this room, in this work, and in every life touched by his legacy. May we rise to meet the standard he set with integrity, humility, courage, and heart. Thank you. God bless you, and welcome to the Clyde A. Poe Men's Health Conference.
Couldn't have said it any better. Brothers of Kappa Alpha Psi Fraternity Incorporated, can you stand on your feet for me, please? All men who are able to stand, please stand. I'm asking you to do this for a reason, because without this person in Clyde A. Poe's life, I'm sure, like many of us who are married would say, I would have been nothing. Today, we want to honor Clyde A. Poe by presenting his lovely wife, Miss Donna, and her family an award. So I want you to put your hands together for her before she rises. Dr. Jackson, Katina, can you come on up? Can someone escort Miss Poe, the lovely Miss Poe, to the podium? And family, you all welcome.
All right. Thank you so much for joining us today. It means the world to us. Mr. Poe was such a beacon in getting the work done, and everything that Mr. Barnes said was so true as we worked with him. We have an award for you, and then Ms. Katina is going to also share some of her story with you. The award reads, the Clyde A. Poe Health Service Award. Thank you for your unwavering support that has helped shape this community with the ideals and vision by Mr. Clyde Poe. The Brentwood Kappas, Matthew Walker Health Center, June 14th, 2025.
So it is the rare occasion that I get to present an award to someone who I know and I love. The Pogues are dear to me. They are my church family. And I knew Clyde personally. And so it's not that I met him through this relationship, but that he reached out to me. And you know when Clyde calls you, and you don't answer the first time. he calls you again. You answer, he said, I'm gonna call you back. Then you don't call back. And this time, you do call back, but not this time. He calls you again. So we go back and forth. And so we got it together. And Clyde whipped this into shape last year.
Yes, ma'am.
And had we known that that was his last act of service, right, we would have thought probably different, but that's why the Lord didn't let us see all the way to the end. But we honored him last year. We honored him, and we honor him this year, and we'll honor him every year after. And so we say thank you to Donna for sharing him with us, for supporting him and encouraging him, and for caring for him. Clyde loved our church, he loved his choir, he loved his wife. And that was evident in everything that he did. And he also loved the black family. And he talked strongly about supporting the black family. And so I think the work that we do through Matthew Walker Health Center, the work that you all do through Kappa Alpha Psi, the work that we all do in community continues to honor him. And so, here you are, Donna. Thank you so much.
I just want to say that I am really pleased to be here, and I'm honored by what you have done today. Clyde has always loved Kappa, and the Brentwood Kappas loved him so much in return. So thank you.
Say one thing, but I think he's missing his professional calling. Talking about Dr. Ryan Myers. Dr. Myers is a native of New Orleans, Louisiana.
That's right. You said it right.
He attended Rhodes College in Memphis, where he received his bachelor's degree in science and biology. He was all conference in a collegiate sport. I think that may have been bowling. I don't know. Cricket. He received his Doctor of Medicine degree from the University of Tennessee in Memphis. Dr. Myers completed his internship and residency at the Medical College of Virginia Commonwealth University in Richmond, Virginia, and served as chief resident for the Department of Internal Medicine. Dr. Myers is a board-certified internal medicine and has an academic appointment as Associate Clinical Professor or Clinical Medical Education for the University of Tennessee College of Medicine. He is a private practice internal medicine physician in Nashville, Tennessee, and past president of the Heritage Medical Association. He accomplished a lot. This guy is a superstar. You would never know he was such a superstar unless you read this Bible right here. Because I think he's something else, but we'll get to that later on. Dr. Myers' leadership extends nationally as past president of the American College of Physicians from 2022 to 2023. In April of 2023, ACP named its summer internship program the Ryan Meyer MD Summer Internship Program due to his passionate commitment for membership and advancing health equity. Round of applause for that. How many of you all had something named after you because you were so good at it? Dr. Myers. Areas of professional interest and expertise for Dr. Myers include independent practice, preventative medicine, health equity, and medical professional mentorship. Before I bring him up, I want you to give him a loud, rousing Dr. Ryan, a.k.a. Comedian Myers.
All right. Well, welcome all. First of all, thank you for coming out on Saturday and being here. Thank you, Brother Hampton, for that warm introduction. So to me, the reason that I'm here, I'll let them get the slides ready, is preventive medicine. It's really what I do. My area of expertise in internal medicine is taking care of complex medical illness, chronic disease management. But if we can prevent the chronic disease, then we're much better off and my job is easy. All right? So part of what we're doing here is to educate. We have a lot in this community, we have a lot nationally, and we hear a lot about healthcare disparities and health equity. And there's multiple reasons why we have disparities. But one factor in that is education. Sometimes we just don't know what we need to know in order to be and prevent the illness from occurring. So that's why we're here, is to educate. It's a non-threatening environment. You're not in my office. I don't have a white coat on. But I'm here to talk to you today, not lecture to you, but talk to you today about a disease that is killing our African American men. All right, so let's get started. So what is the prostate? This is a question that I get all the time. What does the prostate do? What's its function? Why do we need it? And why do we check it? So let's talk about what it is first. All right, so the prostate is a gland that's a part of the male reproductive system. What it does is basically provides lubrication as a man ejaculates and sperm is being transmitted from the man into the female. It provides lubrication and a protective mechanism for the sperm to make it through in an appropriate manner. It nourishes the sperm. It has a lot of ingredients. It has a lot of ingredients that nourishes the sperm and gives it what it needs so the sperm can survive before it reaches a different environment, which is the vagina of a woman. So this is why we have to have a prostate as men, because otherwise we would not be able to conceive, because our sperm would not make it to the other side. Where is the prostate located? So if you look at this anatomy, we all know and can see this is a side view of a man. Where the prostate is situated in the body cannot be physically seen and is very difficult to get to. As you look at the body from front to back, you can see it's right in the middle of the body. The testicles and the penis in front, we can see that, we can touch it, we can get to it. The prostate is so deep, it sits right underneath the bladder that we can't physically see it on exam. We can only feel it on exam. And there's only really one way to get to it, which we'll talk about a little bit more. But understanding where that prostate is, and as you can see, this little, I don't have a pointer, but this is called the seminal vesicle, which is where one of the last places that sperm gets dumped into this channel called the urethra, which is right here. And the prostate, as it goes through the seminal vesicle, the prostate starts nourishing the sperm. And it's giving it all the nutrients it needs, and it's lubricating the urethra. So obviously, when we look at semen, which is that white color, milky color, that's actually made from the prostate, right? So your semen is actually not the sperm. The sperm is inside the semen, and the prostate is nourishing that sperm to make it happen. All right, so by the numbers, we have some stark numbers here. And if you see a common theme on this slide, the common theme is black men. Okay, that does not mean that white men or other ethnicities and races don't get affected by prostate cancer, but the numbers are starkly different when it comes to black men. This is the disparities we talk about. This is the health equity that we talk about. Let's move on. This clicker is not working right. There we go. All right, so what are the symptoms?
Why?
That's $1 million question. And we'll talk about that when we get to the panel discussion. So I want to hold questions when we get to the panel discussion. Talk about symptoms. And I said, well, what should I be looking out for prostate cancer? By the time you get symptoms, it's too late. There's nothing that Dr. Meyer can do for you. So in the early stages of this disease, there are no symptoms. So the only way you're going to know if you have it is to go get screened and get checked. And that's the proactive approach that each man in this room have to take. And that's each lady in this room have to encourage their significant others, their brothers, their husbands, their fathers, their children to go get checked. Because if you're waiting on symptoms, by the time the symptoms happen, I can just pat you on the back and say, I wish you would have gotten here earlier. So don't rely on symptoms. There are symptoms that occur from prostate cancer, but by the time you get symptoms, it is advanced stage disease. I'm just going to go back one. I'm going to touch just briefly on BPH. These are the things that actually cause symptoms. BPH is an enlargement of the prostate, but it's not prostate cancer. It just means the prostate is getting bigger as men get older. And when you have BPH, that can cause a lot of urinary symptoms. So a lot of men will come with urinary symptoms thinking they have prostate cancer, but they don't. But the only way us to know whether it's BPH or prostate cancer is to get screened and also for us to check your prostate. I cannot know it's enlarged unless we're able to check and examine you. We can't guess because remember where it sits in the body, I can't see it. Can't see that it's enlarged. I can only feel it. So there's a lot of controversy, and some of you may not even know there's controversy, but there's a lot of controversy in the medical literature about why we should screen for prostate cancer. And this is for a couple of reasons why. The pros for screening is that we know early detection can save lives. And I'll show you some startling numbers a little bit later here. We know that it's the second leading cause of cancer death in men in this country. The second leading cause of cancer death. Not of just cancers, of dying from cancers. Number 2 in men. The people who say, well, maybe we shouldn't screen for prostate cancer is mainly because there's a lot of inconclusive evidence that it can actually prolong life if you detect it early. And we'll talk about this more. I'm just talking about the people who say, well, maybe we shouldn't do it. Other reasons why is that one of the ways we test is called a PSA test. And it's not a perfect test. Sometimes there are false positives with the PSA test that means something else, and it doesn't mean prostate cancer. So some people say, well, if you don't have the perfect test, why are we using that test to be screened? And my answer to them is, there's no other way. It's the best test we have right now. And hopefully with research, we'll have even a better test with time. But right now, it's the only test that we have. So even though it's not perfect, it's all we have. And then the third reason the naysayers say, well, maybe we shouldn't screen is that some men will have slow-growing prostate cancer. What I mean by that is it may never go at a rapid rate. And it may just be slowly developing where they may actually die of something else other than the prostate cancer. But we don't know who those people are. We can't know that until the end, right? So the only way you can know is to be screened and checked. So let's talk about average risk. And I don't want to spend too much time here because average risk is not anybody in this room. Average risk is for the average male screening between the ages of 50 and 69. There is no recommendation to screen over the age of 70. Because the thinking is some people have slow prostate cancer, as I just mentioned. So if they get it after 70, it's probably more likely to be slow, and they may still live a normal life without having to go under treatment. Once again, we don't know who those people are. We have a lot of different organizations that actually provide guidance, not rules, not mandates, but just guidelines to say, this is what we need to do. And when they talk about average risk, they say each person needs to discuss this with their doctor in what we call shared decision making. Okay, shared decision making is me saying, you're going to get tested for prostate cancer. That's not shared decision making. That's a mandate. Shared decision making is, hey, I want to check for prostate cancer. Let me tell you why, and I want to make sure you agree with this plan and approach. It's between the patient and the doctor coming up with a game plan. The reason I said everyone in this room sitting down right now as men are not average risk. Because of the melanin in your skin, you're considered high risk. Black men and men in the Caribbean with African ancestry, not Latinx ancestry in the Caribbean, but African ancestry, have the highest rates of prostate cancer in the world. Not in the United States, across the globe. So just being black, you are high risk. So all those little guidelines I just the recommendations, they go out the window, because that's not you. When we talk about high risk, those who have a family history of prostate cancer, if you have a first-degree relative, someone one removed from you, father, brother, in rare instances, but a child, that's one person from you, that's family history. If they have been diagnosed with prostate cancer before the age of 65, you have a higher risk than even another black man who's already at high risk. So just understanding your risk and knowing that you are high risk, let's take it upon yourselves to go get screened. So we screen earlier based on family history, and we screen earlier just because you're high risk, whereas the average risk people don't start getting screened until age 50. Let's address the elephant in the room, the rectal exam. Because this is a common reason why I hear why men don't go to the doctor to get their prostate checked. because they're fearful of this finger right here. But as I look across the room, it's not bigger than anybody in here. It's a finger. Remember, we talked about the anatomy. There is no way for me to examine the prostate and get to it except by going through the rectum, making the prostate actually arch up so I can actually feel the prostate. Still can't see it, but that's the only way I can assess to know whether you have an enlarged prostate, to know whether you have prostate cancer. By itself, the rectal exam is not good enough to diagnose prostate cancer. It is a test that's done in combination with a PSA, which is a blood test, prostate-specific antigen. The PSA is actually the primary way that we screen for prostate cancer. But the rectal exam gives us added information. What it does is, it helps me decide if your PSA is elevated. Is it elevated because you have the enlarged prostate? Or is it elevated because you have prostate cancer? It also, 30% of the time, I can detect prostate cancer with the finger exam before the PSA becomes elevated. So when we talk about early detection, this is why we do that test. By itself, doesn't do anything. But in conjunction with the PSA, it is a very valuable test. And they go in combination. The more data we have, the more information we have, the better we can treat the man. It's a 10-second exam. So you can have 10 seconds of feeling uncomfortable, or you can have a lifetime of misery and dying from prostate cancer. I'm going to choose my 10 seconds. Let's talk about diagnosis real quick. I'm not going to spend a lot of time here. PSA is obviously the first step as we get to screening. There's some what we call risk assessment scores that we can do to say what is your risk. Even if your PSA comes elevated, we can say, well, let's look at the risk to see if this is elevated from prostate cancer or from something else. There's some imaging like MRIs of the prostate that we can do once the PSA is elevated to help us locate in the body where that prostate cancer may be. And then obviously the conclusive test is to do a biopsy. Now, because the PSA can be high for other reasons outside of prostate cancer, we like to really take heart to these top three first to determine who really needs to go through a biopsy. Because we don't want to just biopsy people unnecessarily. So we want more information to gather to make sure that we're getting the right information to see who needs to be biopsied. So this is a picture of what a biopsy is like. You can do it one of two ways. You can go through the transrectal, which is a little probe that goes in, and it actually gets little snippets out of the prostate itself. Or you can go through what's called transperitoneal, which is more than what you need to know. But the transperitoneal is between the rectum, the scrotum, and the rectum. So it's not going through the rectum itself, it's the area right between. So there's two ways to do the biopsy. And the biopsy is an uncomfortable test. But we need to know who needs the biopsy first. And then we need to know if this biopsy is going to tell us whether we have cancer. Now there's some new ways to do the biopsy where we can sedate people and give them anesthesia to relax them. So I don't want people to get caught up in the biopsy. What we need to figure out is whether you need a biopsy. And the only way you're going to know that is to go and be screened. Treatment, not going to talk about it much because there's so many different treatments, but there's a wide variety of treatments. If you talk to 10 men who have prostate cancer, you will probably hear at least 4 or 5 different treatments. One had radiation, one had hormone therapy, one had a prostate removed, one had what we call cryotherapy, where they go in and just kind of freeze the prostate. This is determined based on the biopsy results. So we can't even talk here unless we really know what the biopsy showed, because that allows us to make the best information on how the treatment is. Okay? Then the active surveillance is for those that we think may be slow growing. We don't do anything. We just monitor very closely to make sure that PSA is staying in the normal range. And then the last thing that I'll just touch on, and you'll hear a little bit more about this by Dr. Reynolds Barnes, is here's some potential complications that can occur from treatment. Treatment is not foolproof. It's not simple. There are things that can be a result of the actual treatment. Erectile dysfunction, incontinence, bowel problems such as diarrhea, and obviously infertility. So this is one of my most important slides because it says it all. This is looking at a 5-year survival rate for men with prostate cancer. If you catch it early, which is local, there is a 99% chance you will have a normal life in 5 years after you're diagnosed. Okay? Near 100%. But once that prostate cancer is detected late, which is distant, it has metastasized, those who hear the word metastatic, it has spread beyond the prostate. In 5 years, your survival rate is only 37%. So if there's no other slide that is starking to understand why we're here today, is this slide right here. Because if it's caught late, you only have about 30% chance of living in 5 years. If it's caught early, you have almost 100% chance to live in 5 years. So that's why this screening is very important. Prevention, someone touched on some ways why we don't know how to prevent prostate cancer. We don't have if you do X, Y, and Z, you won't have prostate cancer. These are the things that we know are associated with decreasing your risk, but it doesn't 100% preclude you and exclude you from prostate cancer. Staying away from alcohol, nicotine, eating a healthy diet, obviously a lot of fruits, vegetables, high fish consumption, those can decrease your risk, but not 100% prevent. And with that, I will stop and we'll get to the next speaker. Thank you for your time.
Great job, Merharry. Help. I'm on somebody else's laptop, so I'm having a little issue here. Give me a second. Alicia Reynolds Barnes, doctor, pharmaceuticals. For more than 30 years she's been doing this. Dr. Reynolds Barnes has been actively involved in the provision of pharmaceutical care and the implementation of innovation pharmacy services. Currently as the VP of Pharmacy for the nation's largest correctional health care company, she oversees the management of pharmacy benefits, contract operations, and the delivery of pharmaceuticals to justice-involved individuals. She is also the co-founder of Nove, LLC, a digital platform designed to connect individuals with fast and effective wellness solutions tailored to their unique needs. In her prior role as VP of Correctional Pharmacy, she provided strategic guidance to one of the largest managed correctional pharmacy providers. She was responsible for the financial operations and professional performance of the organization. Dr. Reynolds Barnes earned her doctorate of pharmacy from the University of Memphis College of Pharmacy and completed 2 years of postgraduate residency training at the University of Cincinnati Hospital. Look at my favorite part here. She's married to one of our brothers, Brother Daryl Barnes. Daryl Barnes, can you wave your hand?
He's over here.
Oh, there he is. A member of the Brentwood Alumni Chapter of Kappa Alpha Psi Fraternity Incorporated. And has a daughter, Lucy, a recent graduate from Florida A&M College of Law. Sounds like there may be some empty nesters coming on up in here. She said, yeah, hallelujah. Still in your pocket, though, for sure. Right. Still in your pocket. Still in your pocket. Hold on, I'm getting confused on this computer here. I apologize. A recent graduate of Florida A&M College of Law, Dr. Reynolds Barnes is also an active member of Alpha Kappa Alpha Sorority Incorporated. Let's get a round of applause up.
Hey, as the Bible said, he who finds a wife finds a good thing.
Good morning.
Good morning.
First of all, thank you for inviting me. I think this is such a powerful conference and so excited to see you all today. And so happy to present all this, be here to present today. So as was stated, I'm a pharmacist. The things that I'm going to talk about today, though, are around prostate cancer, the before, the after, what can we do? So the title, Stacking the Odds, Co-Conditions, and Prostate Cancer.
You strike me as you may want to walk around a little bit.
It may not. Can I get a little technical assistance?
Tap the pointer on the screen.
Go down, not up. So the young people have a saying that they say, play chess, not checkers. So what's the difference? Checkers is a real simple game. You just make one move, they make a move, you make a move. Chess is different. It's a long-term planning, anticipating your opponent's next move, and then thinking several steps ahead. I feel like there's an echo in here.
We can cut that back off.
So one of the goals that I have today is let's think long-term. Let's think beyond what am I going to do tomorrow. Let's think what happens as we're planning life. So we talked about prostate cancer already, especially happens in men over 50. But the issue with prostate cancer, when you look at the lifespan, is there are other things besides prostate cancer that are going to affect you men. So we're going to talk about something called comorbidities. What are comorbidities? Those are just the other medical conditions that occur in addition to prostate cancer. And why is this important? Why are we even having this conversation? Because this is a prostate cancer conference, so why are we talking about other things? It's the other things that are going to affect what are your treatment decisions. Because you're going to be a partner in deciding. If you get a diagnosis, then the doctor's going to give you those 10 options. And you need to be aware of what's going on with you physically so that you can actively participate in the decision to have a solution. It's going to affect your survival rate. Depending on what else is going on with you, you may not hit the 99% survival rate because you've got some other disease states that we need to tackle now. It's going to affect your quality of life. Dr. Jackson's going to spend a lot of time talking about our mental health as we go through this challenge. But quality of life, not only do we want to live, we want to live well. So the most common comorbidities, what are the other clinical conditions that occur commonly in men with prostate cancer? We're going to talk about 3: cardiovascular disease, diabetes, and obesity. After we all had Krispy Kreme donuts. They were good. So let's talk about cardiovascular disease. What is heart disease? Heart disease is when you have a problem with your heart or blood flow. They make you sick, they make you tired. Your heart's not working efficiently to do the things that you need to do to function. What's important is heart disease is the leading cause of death in men with prostate cancer. So even if you get prostate cancer and it doesn't kill you, let's make sure that we've addressed the heart so that that doesn't, number 1, be the issue, and number 2, affect what we can choose to treat you with. There's some shared risk factors. What can you do? The main thing is let's maintain your weight. If we need to lose weight, let's lose weight. Start an exercise program. And I said baby steps. So let's not just say, I'm going to lose 100 pounds this year. Doesn't work that way. Let's do some baby steps a little bit at a time. Know what your blood pressure and cholesterol levels are. You're going to hear me say this a couple of times. There is a mobile assessment bus out front. Know what your blood pressure is. If you don't know, go out there today and get tested. Don't wait till your head hurts. It's like, oh, my blood pressure must be up. My feet are swollen. Oh, my blood. We call it the silent killer because by the time you get to the point that your feet are swollen, you've already started having some long-term effects of heart disease. Take your medication on a regular schedule. And as a pharmacist, and I will say this, 25% of prescriptions get picked up at the pharmacy. Many of us are like, wow, but many of us have prescriptions we don't pick up at the pharmacy. And sometimes we're in mail order programs where they send them to us and we've got bottles and bottles and bottles stacked up in that cabinet. I'm not gonna say that's anybody in this room, but if you know somebody, then, talk to them. But if you get a prescription and you go to the pharmacy and your insurance doesn't cover it, or the pharmacist says you gotta get a prior approval, and you've been waiting and waiting and waiting, then you call your physician back. Dr. Meyer, when he sees you, he is assuming you've done exactly what he's expected you to do in the last 3 to 6 months. If you know you haven't taken the medication, and then you just show back up, his treatment plan couldn't possibly work because you didn't do your part. So if you can't afford or your insurance isn't covering it, let's get back in and get that prescription changed to something covered. There are always other options. The big one is diabetes or high blood sugar. This is where your body has trouble using sugar the right way. Many men with diabetes have type 2 diabetes. And this is important because all of us know people that are diabetic, and we talk about they have difficulty healing if they have a cut on their foot. We see they have difficulty with their kidneys. They end up with dialysis. This is going to be important because when you get diagnosed with prostate cancer and we have to choose a therapy, then we have to have that conversation of this person is a diabetic. Their kidneys may not work as well. They may not be a candidate for surgery because they may not heal as well. So you've got to address the diabetes before you get to the age of having prostate cancer so that we have the best options of choosing therapies to treat you with. And then finally the big one, I struggle with this one too, obesity. And this is important because when you talk about risk factors, obesity has the highest risk of having the most aggressive cancers. What's also important is when we're choosing therapy and you're going to carry a large mass, then we then have to overcome that additional weight in some of the therapies. Your recovery is going to be more difficult because you're going to have difficulty getting up, moving around after the therapy. So again, it's a comorbidity. Before we get to prostate cancer, the chess move is we've got to deal with heart disease, we've got to deal with diabetes, we've got to deal with obesity, maintaining a healthy weight. And again, it's not a secret. Eat smaller, balanced meals. Move every day. Find something, if it's just walking to the mailbox, do something every day. Drink more water, drink less sugar. Sometimes we substitute our water for sugar drinks. I love the sweet tea at McDonald's. It's the best tea that they make. That's just straight sugar. That's not water. So just because you get a Route 44, you didn't get any water. So do as I say, not as I do. Limit your screen time. All of us have gotten addicted to scrolling. But while we're sitting there scrolling, we're not moving. It's very rare. So we got to really think. Not just kids need to limit screen time. All the adults, Daryl Barnes needs to limit their screen time as well. And in the end, just like prostate cancer, if you need medical support for weight loss, then talk to your provider, get medical support. The thing about care is there are treatment options for all of these. As black men, you tend not to want to ask for help. You'll watch your wife do it. Oh, she's on those shots now. She's lost weight. Line up. Do what you need to do to take care of your health when it's appropriate. And then make small, realistic goals. So again, we're not looking to lose 100 pounds this year. Get 20 pounds off this year and 20 pounds off next year, and you'll be in better shape. So we've gotten to the point where before we get diagnoses, we got some things that we need to take care of so that we'll be more successful should, unfortunately, we be in a situation where we get a diagnosis. Second to that, post the diagnosis, there are some things that happen after prostate cancer has been diagnosed that I want to talk about. Again, hypertension, depression, anxiety. Won't spend much time on that at all because there's an expert comment that will blow your mind when it comes to mental health. Osteoporosis, erectile dysfunction, and urinary incontinence. So a little bit about hypertension. High blood pressure, common cause. It may worsen doing cancer treatment because of the increased stress you're going to be under. Just the planning for appointments, dealing with an illness, everything is going to put that increased stress on you. Just going to the doctor's office, people will tend to have a high blood pressure reading. So get on your medication if you're on it. Take your medication if you're taking it. Lose some weight. Mental health, we all know that the cancer diagnosis is significant and it's going to affect everybody, not only you, but your family. And so we're going to have Dr. Jackson speak about the mental health issues related to that. There you go. So the other long-term effect is osteoporosis. So often the treatment for prostate cancer, specifically hormone therapy, if you're getting hormonal therapy, it will weaken your bones or cause osteoporosis. The weak bones are important because it increases your risk for fractures. And the fracture that we're worried about is a hip fracture. And so studies have shown that mortality 1 year post a hip fracture is 20 to 30%. What does that mean? 20 to 30% will actually die after they fall and break their hip in the first year. So we don't think about that. Age is a risk factor. There's a couple of other things going on. But we have to deal with osteoporosis. We all know that you all are all lactose intolerant. So you're not drinking any milk. We know that. But you got to get your vitamin D in. You got to get your calcium in. If you're struggling with it, then work with your provider, see what your options are for a prescription. Get out in the sun, do some walking and weight-bearing exercises, but you got to get your vitamin D up because as you're going through the therapy, we actually know this is going to be a side effect. You got to protect yourself now in advance of that. One of the ones that we continually hear about is erectile dysfunction, and Dr. Jackson touched on a little bit. Now this is an interesting and important topic because we've talked about some other things. So we talked about hypertension, and we know that some of the blood pressure medications in and of itself and lowering your blood pressure will actually decrease the ability to have an erection. So may have been dealing with that prior. Antidepressants will do that as well. So may have been dealing with erectile dysfunction prior to the prostate cancer treatment, but we expect, depending on the therapy that you receive, that you will have some erectile dysfunction. I think the thing to remember is, and Dr. Jackson had a great slide, it occurs because once you touch the nerves that are around the prostate, we then expect that. I think what we have to know is that we also know that in most cases, not 100%, it is temporary. And those nerve endings will continue to regenerate. Nerves do that 1 to 2 years. But it's a halt. 1 to 2 years from a mental and relationship standpoint. I understand that it's significant, but we should plan for it. We should know that there are treatments for it. Now, one of the things we all see is, I have a 24-year-old, so we're pretty honest. You can tell I'm pretty honest with everybody. But we're pretty honest when we talk. So we see the TV commercials for the Blue Chews, the Viagra's, the Cialis, all those medications. And they can be helpful. They do work. But what's going to be important is you have to have your cardiac status, your blood pressure. You've got to be clinically healthy to be able to tolerate many of those medications. So when we talk about, how do I get through the 1, 2, 3 years as my nerves are regeneration, what are the medications that I can take? Then on top of that, you're going to be limited in the therapies that we can choose if you have hypertension, heart failure, diabetes, all those things. So again, it is a holistic approach. Prostate cancer is our focus, but we got to take care of some medical things. So that when something happens, Dr. Jackson can say, I've got an option for you. Let's try this. In addition to medication, obviously they have the vacuum erection device pumps, and most importantly, there's a number of pelvic exercises. So you will hear women speak often about Kegel exercises where they strengthen their pelvic floor. So, because women have some of the same urinary issues as they get age and muscles get weak over time. This happens after prostate cancer treatment. So men also need to be doing Kegel exercises and strengthening their pelvic floor. Finally, urinary incontinence. I think men are often very uncomfortable with this. But again, when you think about the slide that was shown earlier from Dr. Meyer, and you see where the surgery would be, where the treatment might be aimed, then we should expect some urinary incontinence. Most often, we see it when men have the top treatment, the radical prostatectomy, where they remove the prostate. We're going to have some urinary incontinence. May have already been dealing with it if you had some BPH and some dribbling, but it can happen. So what we're going to do is bowel and bladder training, schedule bathroom breaks, limit bladder irritants, so limit the coffee, limit the alcohol, artificial sweeteners, stay active, manage your rate, and we have to use some pads temporarily. There's some other things that I keep, like she's a broken record, she says the same thing. If you're already having trouble managing your blood sugar, and you find yourself constantly going back and forth to the restroom, being a diabetic, you may have more trouble with urinary incontinence. So we got to get those sugars managed. Got to get your hemoglobin A1C that your doctor keeps saying every 3 months. Where are you? Where are you? Get those numbers to a number that you can manage so that if you have the side effect, we're managing the side effect totally from the prostate cancer and not adding all of the other ones that you can now control to that. So, again, we're going to manage these comorbidities. The most important thing on the slide I want you to know is that I want you to be able to advocate for yourself. You can't advocate for yourself if you don't know what your numbers are. So you need to know your numbers and know where to find them. What is your weight? I know when I go to the doctor and they have me get on the scale, I take everything out of my pocket. I take off my shoes. I try my best to be the least possible. Well, what's the weight and how does that compare to the last time? If you don't know, then turn around and ask. Usually we're just trying to jump off that scale as quickly as possible and get in the room. Ask, how does that compare to where I am? Am I up or am I down? Know what your blood pressure is. Keep a little book. If you have one of the electronic ones now that monitor it over time, know what your blood pressure runs. What does it run in the morning? What does it run in the evening? How does that compare when I go to the doctor's office? Do I even take my blood pressure? When's the last time I've done it, or do I have no idea where I am? What are your cholesterol levels? What's the bad number? What's the good number? Cholesterol is another medication that people just tend not to take. They get a prescription, they might take it, they may not, because you don't feel when your cholesterol's up. You don't feel bad, but when it's too late, it's too late. Know what your heart rate is. Not only what is my heart rate when I'm sitting in a doctor's office, because I'm a little nervous then, I'm dealing with something. What should my heart rate normally run? What is it when I finish exercise? What is it when I'm just sitting at home watching TV? And then finally, and we talked a lot about this, know what your PSA is. So should it start to increase, you yourself can then advocate for yourself and say, it may not be specific for prostate cancer, but I know this is what it's always ran, and now it's here. It's time for me to do something else. It's time for me to advocate. We expect that our providers are going to take our numbers and run with them, but sometimes we in our community have to advocate for ourselves and push our providers. We don't all have a Dr. Meyer that's looking, maybe we should all move to Dr. Meyer. We don't all have a Dr. Meyer that's looking at our numbers. Sometimes they're just moving us right on through, and you're sitting in the car saying, boy, I wish I had said this. So advocate for yourself, know what your numbers are. I think the last thing I'll say is, again, we have a monitoring van out front. You don't know your numbers, go outside this afternoon and let's get started. Get a new notepad, write it down, start today. I think that I'll be I'll end it, but again, I'll go back to how I started. It's time for us to start playing chess, not checkers. We need to be deliberate and strategic, not reactive. Don't wait till we get bad news and decide, boy, I need to lose some weight. We all know we need to lose weight last month. We need to look at the big picture, not the immediate situation. Prostate cancer is not a death sentence. While we're dealing with that, we don't get to be monolithic and only deal with one thing. We're still dealing with life, family, kids, bills, jobs, all those things. We've got to be able to manage it all. And then finally, we've got to be able to outthink. Well, stop from outthink, not outmaneuver. So again, we are not going to react. We're going to plan and we're going to do the work starting today. Thank you so much for listening to me.
She's a native of Detroit, Michigan. She completed her PhD at Tennessee State University in psychology 20 plus years ago. More like 40 years ago. She's I'm just kidding. She's a young lady. She's a young lady. She's a prodigy. She started when she was 12. Just kidding. Dr. Jackson completed her internship at multiple sites. Detroit Receiving Hospital, Yspelante Psychiatric Facility, and Detroit East Community Mental Health Center. Dr. Jackson has a passion for scientific research and has presented multiple research projects nationally and internationally. She serves as the immediate past chair for the Greater Nashville Health Disparity Coalition. In this role, she worked to empower community members in priority populations groups to seek better health, help change local health care practices, and mobilize communities to implement evidence-based public health programs that reduce health disparities across the broad range of conditions. Dr. Jackson believes that if we branch our community together, we can make a difference to the health and welfare of those who we serve. Currently, Dr. Jackson serves as the behavioral health manager at Matthew Walker. She has her own theme music too. In Nashville, Clarksville, and Smyrna locations in Tennessee. Her area of expertise include collaboration with behavioral health coordinators and physicians. In her spare time, she enjoys spending time with her family and friends, traveling, listening to music, and giving back to the community, along with her sisters of Delta Sigma Theta. Somebody stand it for it. Delta Sigma Theta Incorporated. Sorority Incorporated. I want you to give me a rousing round of applause for the lovely Miss Dr. Cynthia Jackson.
Thank you, and it's still morning, so good morning everyone. Thank you so much for sharing with us today and attending this conference. We're really engaged in what we're doing and excited about the work that we're doing. So, as a researcher, I wanted to make sure, can you guys hear me?
Yes.
As a researcher, I wanted to make sure that I pulled some research and that this is not just part of my opinion from my expertise to share with you. So the beginning of my presentation will give you more information about the research, and afterwards I'll give you some other tips. Like Brother Cole used to say, some cognitive behavioral tips on how to make things work for yourself. Down. Got it. All right. So we're going to start with the first journal that I researched. So the way that the PowerPoint is set up, I'm sharing with you the journal, the year of publication, the title of the article, and the purpose in which the researchers decided to do this work. It's important that we use journal articles or research written within the past 5 years. We want to address gaps in the research so we can also start to build new evidence to make sure that we're getting what's most common among us now to do that. So the first article is out of the Journal of National Cancer Health, It was written in 2024. The title of the journal article is Mental Health Outcomes and a Population-Based Cohort of Patients with Prostate Cancer. This journal, which I love because it talks about mental health among populations, those who are diagnosed with prostate cancer compared to the general population. Because of sake of time, I don't go a lot into how many participants there were, how many blacks versus whites, and the demographics, and low income versus higher income. I just want to give you the meat. So we're going to go to the results. So the results in this journal, looking at the general population versus those that are diagnosed with prostate cancer, gives you a little bit of information. These participants were followed over 10 years. The median range of which the prostate cancer survivors were followed was 7.4 years. Approximately 22.8% of patients with prostate cancer were younger than 60 years old. I want that to settle in for you guys. When they got their diagnosis of cancer. Among all of the different types of mental health diagnosis that we looked at, and that included bipolar disorder and schizophrenia disorder and so forth and so on, as common as what everyone else has said in this room, depression and anxiety disorders were the most common mental health disorders among those that were diagnosed with prostate cancer, and in the general population. So no one's exempt. But there were stark differences among what that looked like after that diagnosis of prostate cancer. I have divided this particular piece of work into two categories. So hence the double line. At the top, we look at incident rates of depression, and at the bottom, we look at incident rates of anxiety. Incident rates of depression, and I want to start with the general population because it'll really show you trends of those that were diagnosed with cancer. In the general population, years 0 to 2, so you guys kind of follow me, we're here, years 0 to 2, depression was at 5.0. But with those that were diagnosed with prostate cancer in years 0 to 2, as you can see, the incident rate was 7.3. It increased significantly. At years 2 to 5, for the general population, the incident rate was 5.4, and it jumped up for those diagnosed with prostate cancer between years 2 to 5 to 6.4. You get me? This thing really messes with your mental health. At years 5 to 10, for the general population, the incident rate was 5.0, and again, with those diagnosed with prostate cancer, 6.4. When we look at anxiety, we're going to follow the same trends. For the general population, at years 0 to 2, 4.9. My goodness, year 0 to 2, for those that are diagnosed with prostate cancer, 7.0. Anxiety, based around the cancer diagnosis. Years 2 to 5, 6.4 versus 7.4. Years 5 to 10, 8.4. But look at the cancer diagnosis, 9.9% increase of anxiety for those who are diagnosed. That's very significant. That's why early detection is very, very important. Let's move to the next journal. The Journal of Urology, written in 2022. The title of this article is Association Between Treatment for Localized Prostate Cancer and Mental Health Outcomes. These researchers were looking to compare patient-reported mental health outcomes for men undergoing treatment for localized cancer longitudinally study over 5 years. The results of this study used an instrument to find out what they can find out about your mental health. They used a screening tool we call CESD through the Center for Epidemiologic Depression Study Scale. And they also used another instrument, the Medical Outcome Study, which looked at their emotional well-being. Why is this important? Because it affects the entire family. Consistent with the rate of other malignancies, talked about what Dr. Reynolds talked about, older, unmarried patients had declining emotional well-being, and on top of that, they were at high risk for suicidal ideations. Maybe not take their lives, but felt like life was not worth living. Some people feel if they don't wake up tomorrow, they're okay because they've been in so much emotional distress. Vulnerable populations are those who already had depression prior to the cancer diagnosis, and they were also at high risk before the treatment. My last journal article is the Journal of Epidemiology and Global Health, written in 2025. So this is real current data. The name of this study is Quantifying Suicide Risk in Prostate Cancer, a seer-based predictive model. The purpose of this study was to use existing data for assessing suicide risk among prostate cancer patients. So you see kind of the theme. The prior study talked about the risk of suicide, and now we're assessing suicide risk among those with cancer, a cancer diagnosis. The results of this study show that suicide risk among prostate cancer patients is known to be the highest within the first year following the cancer diagnosis. That's when people think, without knowing the whole educational piece of what can be done, that life is over. And until we can have more forums like this, so we can give more information, people become hopeless. So we want to make sure that they get that information, because if they do, there's a gradual decline in suicide ideations. The more you know, the better off you are. So what does that mean? It means that we need to make sure that we engage in mental health services, that we gather social support from all of our families and our friends and our physicians, and that we balance that timely with our cancer treatment. So here are some things that we know are significant in balancing those. Because we know that it impacts our mental and emotional health, we also know that the diagnosis also triggers emotions like fear. Even the test that you have to have with the finger that Dr. Myers talked about, it actually triggers some of that fear, anxiety, and stress. We also know that sometimes men get hopeless because of the loss of masculinity. It's common. It's life. It's a real deal. We also know that treatment changes can affect your work and your family roles. Hormone therapy may cause mood swings and emotional stability. So family, if you have a person that's going through this treatment, they may be a little different than they were. They may not be as pleasant as they were, but they also have some emotional dysregulation because of the diagnosis. When we look at depression, because we've talked about depression and we've talked about anxiety, there are certain things that you will see start to manifest. Sadness, hopelessness, loss of interest, changes in your sleep pattern and your appetites may happen frequently during this time. The anxiety, it could lead to restlessness, concentration issues, and the psychological distress. It can affect your relationships, and your social interactions. Some men may feel isolated after treatment and routine checkups. We want to make sure we reach out. Talk to them. Is there anything you would like to talk about, or would you like to talk to a professional? Because that's really important. Sometimes men get body image and masculinity concerns. That complicates their whole self-perception. That's where the therapeutic work comes in. We want to manage their psychological effects. That includes therapy and some of the lifestyle changes that Dr. Barnes talked about. And like Mr. Cole would say, good old cognitive behavioral therapy is effective for many of those patients. There are also support groups out there that'll give you a good platform just to share. Sometimes you don't want to tell family members. You don't want to be judged. Join a support group. There are similar things that you can actually talk about and share those experiences and to gather some coping strategies. Relaxation techniques can help alleviate some symptoms. Regular exercise, open discussions about your mental health, and access to psychological support services is very crucial. So I say that to say, just like Dr. Myers is beneficial with some of your physical work, at Matthew Walker Comprehensive Health Center, which is where I love to do my work and offer psychological services, we want to make sure that you know we exist. Sometimes people don't know where their resources are. It's easy to just come in, call, make an appointment. I have an entire team for my psychological behavioral health services that will get you through the malarkey of the switchboard and get you right on my calendar. So we'll share that information with you, but we just want you to know that we're there for you. Thank you guys very much.